It's a great honor and great to see you all. You are seeing the slides?
Yes, very good.
Yes. Great program. I will talk to you about the anatomy for imaging for transcatheter mitral valve replacement, mitral valve repair. Many modalities. Echocardiography is the main modality for diagnosing of the disease and for most of the planning, especially with transesophageal echo and the 3D TE. CMR is, of course, the modality, the gold standard for LV function volumes, and also very important for all the transcatheter therapies today, the CT, and mostly for planning. So, as we know, and all the previous speakers alluded, what is the problem with transcatheter treating mitral disease with transcatheter therapies? And as all of you said before, it's very difficult because mitral valve is really a different animal than the aortic valve. So that's why, after a lot of efforts, and Dr. Ninios brought me memories of the Q valve, the 40s, the 10 dyne, and that I imaged about 10 years ago when I was in memory, and still we're trying to, very difficult to find a valve that can solve the problem as we did for the aortic valve. The images show why it's so difficult and different than the aortic valve. Many structures to deal with, completely the muscle, the chordae, the leaflets, and that makes this procedure to find what's the best very difficult. And as I tell to our fellows, and as Dr. Neo said, the solution is not the transapical. Transapical has been a problem for both the aortic valve, but also for the mitral valve. And for the mitral valve, most important because most of the time the ventricles are already diseased. So if you do another insult to the ventricle, that makes things more difficult. So I think, as Dr. Neo said, and all of you know, the way to go with treating mitral valve disease will be the transseptal approach. And always I say to the fellows, you cannot do a transcatheter mitral valve therapy without to cross to the left atrium. A transseptal puncture, as all of us know, is very important, especially for the mitral clip procedure, for the other procedures. So TE, especially with the 3D modality, the X-plane, is very helpful to see the septum and see where you should do the transseptal puncture. As you can see here, where you see all parts of the septum, the superior, inferior, anterior, and posterior. And all of us know that always we have to look, and the images are the eyes of the procedure. As you see in this case, before a clip, you can see the thrombus on the catheter, and you should detect this and tell the interventional cardiologist to try to exchange and take the catheter out to prevent this thrombus going to the left side and causing a stroke to the patient. As you say before, Dr. Ninios, many devices, and I'm glad I have to say that I have been part of most of these devices, which most of them are not available today, but I will present you the mitral clip, how to do a mitral clip, and I'm sure most of you know, but mostly for the fellows, how to use imaging for a mitral clip. And also, mitral clip has become part of the guidelines now for the mitral valve therapy for both primary mitral regurgitation in high-risk patients. It's a class 2A indication, but also for the secondary mitral regurgitation after guided medical therapy for ejection fraction less than 50%, meeting the COAPT criteria. Also, the transcatheter edge-to-edge mitral valve repair is a class 2A indication. So this case, as you can see, is a flare posterior leaflet, and the X-plane has made things easier. I say to the fellows that the first clip that we tried in memory long time ago, more than 10, 15 years ago, with Peter Block, it took us about five hours because at that time we had not only 2D, so it was very difficult to see the device, to see the clips and the graspers of the device. So today things are much easier. We deliver a clip in less than 5 minutes. As you can see, So what we do, we use the X-plane and we go across from one side to another and we try to see where the MR is coming from and we try to measure the leaflets because the length of the leaflets is very important, as you alluded before, to prevent dislodgement of the device. And we want to see at least 7 millimeters length of leaflet for the small clip and at least 9 millimeters for the big clip before we go ahead and to do this procedure. And also valve area is very important, and we prefer to have a valve area of more than 4 centimeters, and we do this with 3D, but also gradients. We want to see low gradients, and it's very important to know the gradient before you start, so you will know when you finish and compare. So this is a case here. As you see, we move the X-plane from one angle to another just to see where the most of the MR is coming, the location of the MR, and at that point to see the length of the leaflets. And most of the time, the posterior leaflet is the problem. As you see here, again, the same, now we're in the lateral part, and you see in that area, the leaflet is a little bit short. So very important to know this and plan this before the procedure so you don't have to deal with it during the procedure. And 3D has made things very easy for us today. It was difficult when we started in the Everest trial. There was no 3D, there was all 2D. And this is the surgeon's view, as all of you know. Lateral is the left lateral appendage, just to remember. You put the aortic valve at 12 o'clock, the anterior leaflet with A1, A2, and A3 scallops, and the posterior leaflet with P1, P2, P3. And of course, today we're able to talk the interventional with the imagers to know exactly the anatomy and the location. So this makes things move very fast in the operating room. Another thing that we always do is we check the pulmonary vein flow, and this is the left upper pulmonary vein, because you get some objective evidence after you do the clip and see if this flow is better, and this change in flow before with after the clipping gives also very prognostic information. This is systolic reversal in the right upper pulmonary vein that you see here. Also, we try to use fusion imaging, not very often, because it's not, to our experience, therefore it's supposed to be. It takes actually more time to use this, but just for meetings, as you can see here, is for a transeptal puncture, makes things easier between the imager and the interventionalist who does the procedure. So again, very important, the transeptal puncture here, crossing with the catheter, guiding the delivery of the clip, as you can see here, to prevent any injury of the walls, and then bringing the clip down to where you think is the mitral regurgitation. Sorry for this. Again, we use a 3D just to make sure that the clip is perpendicular to the commissures of the mitral valve. We want to make sure that the clip is on the mitral regurgitation. And then when we come into the ventricle, we decrease the gain on the 3D just to be able to see the clip below the valves in the ventricle and make sure that the perpendicular to the commissures position is maintained. You open the clippers, and now I remember when I talked to the company when I was in Emory, that they have to make the clip to be able to work this independent, to have the clippers work independently one from the other. So if you have a good grasp to one of the leaflets, then you keep that and you try to reclip with a better clipping of the other leaflet. So this also has made things much easier and also less painful, less time. You clip one if it's good, then you try to clip the other one. So very many improvements on these devices to help us do these procedures faster. As you can see here, a second clip lateral to the first clip because of the residual MR. sorry for this, this in zoom view. And then we measure the gradients before we release the device. We don't like to have more than 4 to 5 in the orifices around the clips. But of course, this is always, you have to see what the patient, you have to know the story of the patient. And but about 4 to 5 is what we usually accept. Sometimes we have to, not deploy the clip if the gradients are higher, and we, as you said before, you develop mitral stenosis trying to treat the mitral regurgitation. So this is before deployment, 2 clips in this case, improvement of the pulmonary vein flow, which, as I told you, has prognostic information for, and it's also, you get some objective evidence. If you see the flow better, then you know that you really did something good for the patient. This is another case with FLEL posterior leaflet, severe mitral regurgitation. Important, very 3D, very important to see the anatomy of the, and this is after 2 clips, minimal mitral regurgitation. Very good effect of the clipping on these primary mitral regurgitations, with high surgical risk, prohibitive risk for surgery. Actually, if you clip the FLEL part, usually the mitral regurgitation is gone, and we have very good results in these cases. So, moving to the transcatheter mitral valve replacement, as Dr. Ninios precluded before this, very difficult, and the problem is that it's a complex saddle-shaped anatomy of the mitral valve, the proximity to the left circumflex, and most important, the proximity to the LVOT. Apollo is a trial that we do here, and is now transseptal, and also now we're part of the smaller delivery system, and we will have few patients for this smaller device, 2 sizes at present. And this is a case of severe mitral regurgitation that underwent the same interpreted therapy with the Apollo trial. Based on the CT measurements, the size of the device that was selected was 42. This CT, as I told you, is very important, especially for the transcatheter mitral valve, to check the LVOT and to predict the neo-LVOT size. Also the artomitral angle, in this case everything was favorable. Artomitral angles, you want to be wide, more than 120 degrees. In this particular case it was 154, and the LVOT, neo-LVOT was 525. No risk for LVOT obstruction. Again, transseptal function is very critical. This is a safe device to cross the septum. Crossing of the septum, ballooning the septum. And this now is the valve. Ready to be deployed. Here is deployed. Sorry for this, too many movies. But anyway, a great result, and this is the gradient through the LVOT, as you can see, 3, mean gradient of 3, peak gradient of 7, and as per the neo-LVOT was no risk for LVOT obstruction in this particular case. What about the valve in valve? This is a case that we did last Tuesday, actually with Professor Dangas. So in this case, the angle was, as you can see, 109, which is not a preferable angle. You want, as I told you before, to be more than 120. And also the neo-LVOT here was 81 millimeters. So very high risk for obstruction, as you can imagine. And we used the Lamboon procedure. As you can see here, the catheter in the anterior leaflet, This was a prosthetic mitral valve. The patient had a prosthetic tissue valve, as you can see here, and you can see the catheter for the Lambeau procedure. Again, this is the leaflet, the anterior leaflet, very easy to see. This is explained trasophageal echo to see the catheter going through the anterior leaflet of the prosthesis. And you can see here the laceration with the color Doppler of the leaflet. And now is rapid pacing, 26 mm Sapien Resilia was deployed. Great result, no MR, no paravalvular leak. As you can see, this patient, Laboon was critical. Without Laboon, would have been a hemodynamic collapse. And we know that because the NeoVOT prediction by the CT was 80. And as you can see here, what keeps the Laboon procedure made this possible. You can see the flow through the anterior leaflet on this case. Without this, it would have been catastrophic. So, very good prediction by the CT. And this was a gradient, peak gradient of 20 after the procedure. Thank you very much for your attention. And as you know, in your places too, this is an effort of many teams to make this happen. But it's a very rewarding field, and all of us are glad to be part of this field going forward. Thank you very much for the privilege to be part of this meeting.
Thank you very much, Dr. Lerakis. It was great to get step-by-step guidance of the echo contribution and measurements. Any brief comments before we move to the next?
I think it's very important to emphasize the role of imaging, both in the selection and the procedure itself. Without eyes, you cannot see, and imaging is the eyes, and multimodality imaging is very important, especially when it comes to mitral valves. So I think this lecture highlighted everything. That's it from me, really.
Any other comments? No? Well, thank you very much. I appreciate your contribution from New York. Thank you again.
Thank you very much. Have a great rest of the meeting. Thank you.